All right. Would you all like me to start?
We sure would.
Yes.
Okay. Well, I want to thank Rita Carlson. We've been working together for several years now and kept in contact. And she invited me to present to you. We tried to plan this even a couple years ago, and for lots of reasons it didn't happen. But I'm really glad to be here to present with you. And I'll kind of move on. I'm basically wanting to promote the use of orthoses. Some of you may actually use these devices. And my goal here is to just provide you a little bit more insight and perspective on how a clinician looks at providing these devices, particularly for individuals with post-polio. I thought it might be helpful just to give you a little bit of my background. I wear several hats. I am a bioengineer. My PhD is in bioengineering, specifically in foot and ankle biomechanics. One of my specialties is biomechanics, specifically in foot and ankle. And then I am also a certified clinical orthotist and was practicing for very many years. I started my education at Wayne State University in Detroit. I actually got a bachelor's of fine arts degree. That's a long story, but it's actually helped me out quite a bit. I then went to Northwestern University for my orthotic training. And then after that, I went to University of Strathclyde in Glasgow, Scotland as an external student and did my PhD in foot biomechanics from there. My clinical experience and academic experience started off in Columbus, Ohio. I then went to Miami and Florida for about 8 years. I was in clinical practice for 4 or 5 years and then went to Florida International University where I began teaching orthotics at a bachelor's of science program there. I was there for about 5 years and then I transitioned to Southern Illinois University School of Medicine where I was in the Division of Orthopedics, Department of Surgery. That is where I did most of my PhD research, but I also maintained a clinical practice within the medical school. After that, I spent 6 months as a visiting professor in Jönköping, Sweden, teaching orthotics, as well as conducting research. 3 years at Springfield Clinic in clinical practice again. I was at Georgia Institute of Technology for 12 years. And that is where I just left and just joined Kennesaw State. And so I think it's important just to get a little bit of background where I'm coming from. I'm no longer in practice. I'm engaged in teaching and I'm engaged in research, and I'll share a little bit with you on that just to kind of show you how that clinical perspective gives you a little bit of insight to answering various research problems. So an overview of what I want to do today is I'd like to first start with a commercial. That commercial's on Kennesaw State University's new Masters of Science in Prosthetics and Orthotics. I just want to give you a little bit of background of what's happening there. Then the main talk is really on perspectives on post-polio syndrome. And as far as I know, just for the age of post-polio survivors, they're very well informed. You are all very well informed. You probably know more details about post-polio than I ever will. But what I hope to do is give you some insight to the basic fundamentals of how a clinician thinks through problems specific to post-polio, because I find that might be helpful, particularly if you're having to seek further treatment for post-polio syndrome and how you might go through that decision-making process. And in doing that, I'm going to talk about basic orthotic treatment goals, motion control of the knee and ankle, which is how we treat you with devices, management of joint deformity, talk about our main goals of safety, stability, protection, and function, and then introduce you or just share with you some perspectives of some of the devices that you see online that you probably are using. Maybe you have some questions on those, and I've just taken a kind of a survey of those that I hope to go over and explain a little bit what they mean and how they might be able to help you. So to start with, we have a new program at Kennesaw State. I just joined the faculty in January. We are going to be located about 3/4 of a mile off campus. This building on the bottom here is where most of the night courses are taught. It has free parking here, and our laboratories, our clinical and technical labs, will be located in this building right here. Those labs are currently being built as we speak. So we expect that this program, the way it's being conceived, to be kind of the center for the Southeast and even the nation. We hope this will lead to a center of excellence with 3 domains: research, education, and service, and that is clinical service. So this program originated at Georgia Tech, where I came from. It started in 2002, and like Georgia has led the nation with the developments that happened in Roosevelt Warm Springs with some of the early developments in the field. Georgia, again, is the leader in the education model that exists. At Georgia Tech, it was the first Master's of Science program in orthotics and prosthetics. Prior to that, you could only enter the field with a baccalaureate degree. It also offered the first PhD training program in the country that was coupled with the MSPO program. And we had a fantastic success, on that run at Georgia Tech. So some of these changes were, we advanced from the baccalaureate to the master's degree with that Georgia Tech program in the lead. What it brought is that at the time, at the undergraduate level, you got a bachelor's in prosthetics orthotics. What happens when you move to the master's degree, students come in already with a skill set, many of these in engineering, exercise science, kinesiology, and so the field gets enriched immediately because you have these other skill sets that contribute to the clinical training. The timing of when we moved to the master's degree was really helpful because science and technology has been advancing at record pace, and these skills that these new students have come into can now translate that into prosthetics orthotics. Another thing that's happened is that we've had a lot more women enter the field, and it's been a reverse of the gender gap as a result of that. So here's where we look to the future. The prosthetic orthotic program is really critical because of what's happening right now. There's a shortfall of practitioners being produced, largely because there's an increase of need due to the aging population, due to the wars and the wounded veterans returning, and then clinician retirements that are occurring. We're not being able to replace quick enough. Globally, this is occurring. There's 100 million people that need our services. There's 1 billion people that need assistive technologies. And as you know, orthoses and prostheses are assistive technology. And then here in Georgia, particularly in the South, we have a public health crisis of diabetes, cardiovascular disease, obesity. All these lead to amputations. They also lead to strokes, which all require our services. And here's where the problem lies. There's only 13 schools in the country. There's about 3 or 4 that are kind of in the hopper that may be coming on board. There's only 2 kind of in the area. There's one in Alabama State. There's one in Florida that is just starting up again. And and we feel like we're going to be the center of the South with what we hope to offer. So it's one of the challenges why there's so limited schools. Primarily, it's very expensive to run our programs, to the point that there's actually in Washington some movement to help fund our educational programs. One of these is the Wounded Warrior Workforce Enhancement Act. Actually, this year it was activated again to try to get money to fund these schools. So if we can get some money from the federal government, it may really help advance kind of the shortfall that we have. Okay, with that, I'd like to move into something a little bit more relative to why you're on this Zoom call. So I am going to focus in only on lower extremity problems right now, because my main function or my main interaction with individuals that have post-polio is really to keep them moving, keep you all moving, and a bit more functional and independence. And so I just kind of wanted to review these 4 or 5 areas that seem to really plague the change that happens with post-polio syndrome. So there is this gradual muscle weakening. And when I say that occurs right after the acute symptoms, patients tend to kind of balance off after they've been rehabbed. And you go decades and decades with pretty much no big changes and can be quite functional. Then all of a sudden, this weakness creeps up and things start to happen. And as far as we know, most of this occurs in the muscles that were originally weakened when the infection occurred. And so you get this slow and progressive muscle weakness. Related to that, you have fatigue. Now, that fatigue can be muscular and it can be generalized. It's difficult to kind of differentiate these. What is associated with that is some of the residual muscle that was there that may have been affected by that acute polio infection. There's a secondary atrophy that occurs later in life. And then there's some joint pain. That joint pain is related to partly some joint degeneration that occurred over all those years, and then some of the deformities worsening. And so you get this grouping of problems that now surface, and they kind of complicate a revisiting of, is there further things that need to happen to help resolve the problems. But these are the fundamental things that we're going to kind of focus in on. So some of the symptoms, there can be relative periods of stability, interspersed with periods of decline. It's probably the best phrase that describe what happens. Is it's very slow. There can be something that creeps in, and then we have problems, and then you may seek the advice of your doctors to see if these can help. Then associated with this, and one of the problems that practitioners have is trying to find out how these symptoms, as they start to surface for a patient, what can we expect to happen in a year, a few years with them? How bad would those symptoms affect someone's functionality? We just don't know. It's so individual in how it presents. So once someone is diagnosed with this post-polio syndrome, what it ends up doing, it creates new challenges for patients. So for decades, you've not had all these problems. All of a sudden now you're being challenged with how to protect yourself. And these things may now influence the orthotic recommendations that you've had. So you may have used an orthosis for years, and all of a sudden you have a decrease in your functionality. You go to your orthotist, and they're now changing your prescription. And you're saying, like, why do I have to move to this new treatment? And oftentimes that involves a different device that is more protective. And there's quite a bit of resistance from patients to move on that when you've been accommodated for so many years. I'm giving you insight to the feedback and how a clinician internalizes that. And of course, these complications influence both mobility and independence. And some of the changes can be permanent. So how does a clinician approach this? And I've tried to look at 3 or 4 treatment goals that we typically have. So one is we try to allow for the maximum amount of movement that is possible for function, for walking and movement. So sometimes we want to block movement, and we have to as part of the treatment. But in general, we want to see how much motion can we retain for an individual. One of the treatment goals may be to reduce pain. Maybe one of the new symptoms you have is you're starting to have pain in your knee, pain in your ankle, and there is a goal in how we treat that pain with the orthosis, and that may be, another one of the goals that we're trying to target. And then there can be an increase in deformity. There may be deformity present prior to you being diagnosed with post-polio syndrome, but all 3 of these goals often are combined, and some take a priority. Often pain is the one that really takes the priority for most patients. And so now I'm going to say, okay, so now we have these as possible treatment goals, and their priorities change with the individual. And then this is one of probably the most important one related to those, and that is to hopefully keep people moving and functioning and staying independent. So this is what a clinician is trying to do. And through conversations of what the goals are for the patient, hopefully we can come up with a strategy for how your orthotic management may change. So to try to really simplify this, to understand, to appreciate it, the only thing an orthosis does and how it does it is it controls motion. So all those treatment goals that I just showed you, the way that we treat them are summed by controlling motion. And that is it doesn't matter if the orthosis is for the spine, the upper extremity, the neck, the lower limb. That's the main thing. What we do is we try to control motion. And I'm going to show you how simple those techniques are, and also how complicated they are to do it correctly. So we're going to start here at the knee. Often the knee and the ankle can be affected in the lower limb, and or both. So here's a normally aligned knee. And one of the common muscles that can be affected is the quadriceps, or the knee, the muscles that extend the knee. That muscle is critical because that muscle is the one that allows you to stand. And so that big muscle belly in the front of your thigh attaches to your kneecap, and then another element of it then attaches to your tibia. And so that is required for standing. So if that muscle becomes weak from the the infection, and or it is totally non-functioning, we have a problem with standing and walking. And so now there's no stability at the knee, and it flexes, and no one can bear weight on it. So with survivors, sometimes they can adapt to this by changing the way their body weight goes through their lower limb, and they can walk without that muscle to still be mobile. But that's not the way we treat it. If it's too weak, or we have a safety concern, we do a couple things. So how do we control movement to prevent that from happening? Is we kind of have forces. This is actually called the three-point force system. And in this case, to control this motion, you have you apply force at the back of the foot, at the upper thigh, and towards the knee. So, and I have 2 arrows in the front because I want to point something out. In the old days, probably in the 50s, they used to have just one point of force, and it was at the kneecap. And we learned in the 60s and the 70s, people that were fitted with these knee, ankle, foot orthoses, these KFOs, that they were getting arthritis of the knee, causing pain. So about that time, they transitioned and they no longer placed a force on the kneecap. They went just above the kneecap and just below. So I'm talking about how there was a progression of change, and it occurred because we learned this from polio survivors. Okay, so this is the way we manage it and provide stability to the knee. So if those forces come together from the front and the back, they can provide stability to the knee. And so we achieve that with an orthosis. And so let's assume all those elements are rigid. The two in the front of the leg near the knee, those could be straps that you may have. And this is how we acquire this straightened part. And so usually there's a joint at the knee so that you can sit, and then we lock it. And now we've substituted that weak quadriceps muscle, and we can provide stability through this mechanism. So that's how we control motion of the knee. Now, sometimes we need to control the knee from going backwards, which is hyperextension. I'm going to go over some of that in detail towards the end. But this simple motion control is the way that we treat all those goals that we went over: the pain, the deformity, and also to maximize movement. We just control how much we provide. Okay. So there's another technique. This is one technique in which we can control the knee, but there is another one, and it doesn't always apply. It depends on the magnitude of control that's required to the knee where we go this way. So this is how we do it at the ankle. So if you observe this is someone weight bearing, and let's say their knee is weak, so it can't support them. And if you see the angle that occurs at the ankle, if essentially the ankle dorsiflex, in other words, the tibia bone angles forward, and that always happens. So if we can control that tibia from moving forward by another means at the ankle, we can actually support the knee above that, like this. So we go back. This is what happens if you don't have knee support. But if we control the ankle and we keep it locked at 90 degrees, we can bear weight through the knee safely. So this is one of those mechanisms. So how do we do that? This is where this is an ankle foot orthosis. I'm sure that you're somewhat familiar with these. And that AFO is basically blocking or preventing that tibia from moving forward. And now we can get knee stability. It doesn't work for anybody, but these are two mechanisms of how we get that motion control. Now, the degree of motion control with this ankle device depends on how stiff the material is there. And in this case, this would be called a solid ankle AFO. It goes near that ankle joint. And if that plastic is really rigid, then that ankle will move very, very little. And so that is what the orthotist controls to determine how much control is going to be at the knee by controlling the material and the trim lines, or kind of the degree that it wraps around the ankle. So here's another version of an ankle. It has a similar appearance, right? But there's less plastic. And you can imagine that that plastic may bend forward and still allow some movement of that tibia in a forward direction, so it has less stability. There's less control. And the reason why I show you this is that, let's say that this is the device you've been wearing for 30, 40 years, and you're quite happy with it. And all of a sudden, that quadriceps got a little bit weaker. You don't have as much stability. And so even though you've been using that for 30, 40 years, you may need that guy, which doesn't let your ankle move like it did before, but it's going to solve a whole mess of other problems down the road that you may be dealing with. And so this is the option to increase. This is kind of like taking the difference between taking 250 milligrams to treat something, and 500 milligrams. This is the 500 milligram version of that. So this is the dosage, and this is the decision that the clinician will make with stability. So the 1,000 milligram one is that knee orthosis one right here. Okay, that's the difference of what's required and what we have to work with. So again, it's that is how we control that stiffness, and that's how we control the motion that occurs at the ankle as well as the knee. So you know, this is what these are the lectures I give to my students. This is Orthotics 101 and provide that similarity. But I think if you understand how this works, it will help you with some of your decision making when you're talking to your clinicians. Here's another one of those devices. I'll go back one just to show you. So we call this a strut just because that's what it is. It's just a plastic strut that's somewhat compliant. This is the same device, okay? And we're now talking about, again, how stiff is that strut in that region. In this case, there's a version here I'm going to show you in a minute. This is a carbon fiber version. And actually the part right here is totally stiff. It's almost like steel. And so we're saying we want that stability, but we would love it if the ankle could move a little bit. Well, we're not going to make the ankle move a little bit, but in the foot section here, what they do with this particular device is that this carbon fiber down here is somewhat compliant and it does bend. So you can kind of get the movement that occurs at the foot, not at the ankle, but you still can get that stability at the knee, right? So again, this is just a different version than this. And there's advantages and disadvantages. And I'm just showing you like what goes into the, one design over another. Okay, so that was discussing stability at the knee, stability of the ankle, and how we control those motions. And now we're going to talk about a different one. That was for stability during standing. Another problem associated with a weakness is that when your leg swings through to take another step, sometimes you need to control the motion of the foot and leg. So what happened, this is a drop foot, and that's often common with post-polio, as some of you know. And it's like, here's how we control the motion. Here's that 3.4 system again, but it's just controlling different skeletal segments than before. And so this is what we're trying to do. That's how it does it. It holds it that same way I showed you. And I'm giving an example with a strap that is providing that force to kind of hold that foot up. And the goal is that if you're swinging the leg through with a drop foot, the leg can be artificially longer in some instances. And so the goal is when that muscle fires, it provides clearance. And that's what we're trying to achieve here. And this gets back to, again, how stiff do we need it to provide that assistance and replace the loss of the muscle function of this muscle right here that pulls that foot up. So this is the substitute. It's like a prosthetic substitute for that muscle. And again, we're now back to discussing how stiff does it need to be here to accomplish that. Okay, so now I've discussed a little bit of some of the way we control motion. And now let's talk about some of the deformities, the common deformities that are associated. I have this as an extreme version of someone that's had polio, pretty significant. But what's nice about this is it has quite a few of the deformities, and people have varying amounts of these. So in this case, if I would review this, we got a couple things going on that look pretty obvious. We have a leg length discrepancy that is very common with polio. There's some real advantage to that. I'm going to talk about that in a minute. It can be a disadvantage, can be horrible, but from a clinician, it can be really helpful. And I'll tell you about that in a second. And then in this case, there's a foot size discrepancy too. So the foot and the leg were undeveloped because they didn't have any muscles that were around those joints to kind of help provide force and load through the skeleton so that it could grow normally. Okay, so let's call it for a deformity, for lack of a better term. And then there's a drop foot associated with this. And all those things have to be accommodated before we can even consider doing any motion control elements. So there's additional orthotic interventions that have to go. We need to accommodate for the foot size discrepancy. We need to make up for the length differences. Okay, so here's another factor that goes into the design of the device and the actual prescription, or how the orthotist will engineer that orthosis. So the question is the deformity fixed or is it flexible? And so, when you get a drop foot initially, oftentimes it's paralyzed. There's no way that the muscle can go, and the foot can flop around, the knee can flop around. It depends on if both sides of the joints, the muscles are affected or not. Well, the way that we treat that is different. If it's a fixed deformity, we have no ability to actually change the fixed deformity component. So what we do is we accommodate it. If it's flexible, that means it moves. Then the clinician has the option to decide what is the optimal position I want to place the joint in, whether it's the knee or the ankle, for optimal function. So that actually can predict, that actually can limit the devices that are selected, sometimes for that reason. And so these are some of the factors that come into play with post-polio, and its impact. So now let's go over a couple common ones, and then we'll review. So in addition to that, sometimes these deformities that we see here were not there initially, right after the acute infection, but over time, through weight bearing and use, deformity can set in. And in the beginning, if we see someone with post-polio, we don't do that very often here in the US anymore. We know that the progression of the deformity will lead to something like you see in that, in that right leg of that individual. And in this case, there's arthritic joint changes that are degenerative, that leads to this. And that alignment causes all sorts of problems. It can cause pain, and we want to prevent that from progressing. So one of the features of that treatment is to prevent that from occurring if we can. Typically, this happens when we have someone that has been ambulatory successfully, where they're weight bearing on their limbs with no orthosis to support their knee. And over time, although they're able to walk independently without an orthosis to help them, deformity can set in as a result of that. So one of the reasons that early intervention is to protect and prevent deformity. And that's why that triad there of what the treatment goals have to be considered, have to be a factor. Now, in post-polio syndrome, you may have mild deformity. In other words, it's just like a small little bowing or a little bit of hyperextension, like in the back, in that second radiograph there, that X-ray. Those kind of things can happen, but they can get worse. And so sometimes you may have gone for years again without containing that. You've not seen any progression in those deformities, but now all of a sudden you've got pain, and only a change of a couple degrees in that joint malalignment can cause that problem. And so even though you've not been able to, you've gotten away without protecting the joint, walking without anything, now all of a sudden, if you want to get rid of your pain and you don't want to prevent further degeneration, you have to protect the joint again. And that may be a new treatment goal that was not there initially, that you've been working on prior to that. And so this is how joint deformity can resurface with post-polio syndrome, and has to be treated differently. So So let's kind of go over what the changes are that happen with post-polio syndrome. So again, you recover from post-polio survivor, recovers from that acute infection. Decades and decades, everything is great, functioning in society, doing really well. And then all of a sudden, some symptoms start to arise that you know really well now. Some weakness, some fatigue, joint pain, all of them, all of the above are only one. And we would be focusing in on how do we treat those symptoms that are causing a problem for you. So let's go to the top there. And this order may change on how you perceive it. But almost with any orthotic management, these are the things that we look to do to help a patient. We want to ensure their safety. We want to make sure that an individual is not going to trip, that they're not going to fall. Particularly with post-polio syndrome, with an aged population, the last thing you want to do is break a hip or fall on a knee, particularly if it's been replaced or something, all these kind of things. So we want to prevent and protect that. And all that relates to stability, even something as simple as standing. We want you to be able to stand for long periods of time. We want to provide stability that when you're on one leg during the walking cycle, you want to know that that knee is not going to buckle. That ankle is going to provide enough support for you. And then function, we want you to still be able to walk and do all the things that you used to do. And then protection, this is specifically about protecting a joint, to preserve what you have, to make sure that it doesn't become a constant, another set of symptoms that you're dealing with that are secondary to do it. So these are the things that we look at when we're considering treatment. Now, one of the hard things that we have in approaching the post-polio syndrome is that we have this added set of symptoms that are associated with normal aging. And if you didn't even have post-polio syndrome, let me tell you what, we still have patients that come in and just with the aging process have issues with degenerative joint disease, not from polio, same deformities that look exactly the same, and they have knee pain and they have ankle pain. They can't stand, they're tripping. That has nothing to do with post-polio. And so you combine those two, and it's hard to detect which came first. And so this is what kind of complicates it. And to me, that's just like a kind of another layer in your decision making. So now you've been diagnosed, you have these new challenges, and those new challenges are somewhat obvious. If you've been affected, you can have a reduction in your normal activities. You can't walk as far. You don't feel as stable. You may trip. You may not have tripped for years, or you're tripping many more times than you normally do. And then perhaps episodes of falling. And then you may have pain in several areas, and it may not even be the areas affected. Let's say that you've got pain in your ankle, but you've not got pain in your hip. The pain in your hip may be related to decades and decades of walking with a new walking pattern to accommodate, a drop foot, even though you're using an AFO. And then increased deformity. So these are all the new challenges that now come into play that have to be considered in offering you a treatment plan, if it includes an orthosis as part of that treatment plan. Okay, so here's where I'd like to go over just a little bit of some of the new devices and can they help you? And you have I think it's fantastic that you have this group of individuals that can talk and discuss what your experience are with these devices. And from a clinician standpoint, sometimes that can be worrisome because you have someone that's reporting that my orthotist gave me this AFO device, and let me tell you what, it has changed me. And you're going to say, wow, I'm going to go to my orthotist. I want that device too. And what I'm hoping to do by giving you that foundation of the principles we used to control movement. And what I'm going to show you now is why one device may work for someone, may not work for another. And so I'm going to go over and pick through what the advantages and disadvantages are of these symptoms, of these different systems, AFOs and KFOs, to just give you a little bit more insight. Because typically when you go see a clinician, he's not going to lay out 20 devices in front of you and say, we're going to select 1 out of 20 here for you. And which one's the best? I wish it was that easy, but we're going to go through quite a few right now and kind of talk about like how you might approach making the decision. So, so some of the differences between technologies and materials, and how a lot of things have not really changed a lot. That's the most important thing. So on the left is more of a traditional metal leather system that many of you, you know, at your age now probably saw in your youth, maybe wore one in the youth, or still are wearing devices like this. That device right there has a aluminum metal calf band with a leather cuff. It has aluminum uprights or sidebars on it, and then it has a joint at the ankle and has a metal stirrup that is attached to a shoe. And despite that these type of devices are not that popular anymore, those were fantastic devices. And how many people have been restored their function? The simple is it's a motion control device, just like the other devices we're going to show you. Here's a thermoplastic device there. That device accomplishes the same thing. It has a couple advantages in that the device on the left, back in the day, those were attached to the shoe. This device can be placed inside of a shoe, but it still has a joint. It still has the 3.4 system that we talked about controlling the ankle. Both of these devices, depending about how that joint is set, could provide some knee control and not have you move to a KFO for that reason. So all this is just a change in material. And each one has its advantages and disadvantages. So, I'm taking this as kind of the starting point. I would say that these would be characterized as conventional devices. Both are custom. They have to be custom fit to work properly in most cases. I will point out that the one on the device, this is an important distinction. As a clinician, we would call that a custom molded thermoplastic AFO. And when I say that, the custom molded means that it required the clinician to physically take a mold of the user's or the patient's leg, and the device was built off of that. So you have to take a mold, custom molded. That's distinctly different than the device on the right here, which is a custom fitted device. That's a device that you can buy off the shelf, small, medium, large, left and right. And the difference is it might have a longer foot plate. It may not have a strap on it. And we call that a custom fitted device, as it was not made from a mold. And the reason why I'm telling you that distinction is that the reimbursement for the clinician or the amount of money that's paid for that device is totally different. It's usually higher because there's more processes involved to create the custom molded one here on your right. So, so this is another thermoplastic device that have been popular for many, many years. This left one, the difference between the left one and the right one is really the amount of plastic that's surrounding the leg at the ankle and foot. And again, that's where we're getting the motion control. The clinician is going to decide how much stability that the person is going to need when they're standing and walking in it. That stability may be for knee stability. If the knee's not involved, it may be the amount of force that's required to hold the foot up just for ensuring that they're not going to trip. That's kind of where the decisions are. Very lightweight, You can put a shoe in and out of it. And some of you may actually be using a device like this.
Oh, maybe she took it.
Huh?
Maybe she took
Okay.
it up.
So then,
Flash. Well,
same.
look on top of the wine cooler.
Someone needs to mute their mic for the group. Okay. So here's another technological advancement. These are called composite devices. They're made out of a different material. They're made out of a material that combines many different things. It can be carbon fiber, which is a fabric made out of carbon. And when that carbon fiber fabric is surrounded by a liquid that solidifies, which is called a resin, it can be very rigid. And those fibers now are very, very strong. And an advantage is it's very lightweight, but you can also have strength that's greater than even steel. You can control the amount of flexibility in parts of the carbon, and you can make them very compliant. So here's several different versions. Some of you may actually be using these devices, and you're like, well, which one is good for me? What's the difference between them? So I want to go through one. So the left one on the left has, these are all strut designs, various strut designs. The one on the left, this is a carbon strut, often called a leaf spring. So let's go back a couple slides here. This one right here, that's called a leaf spring slide. The only difference is it's made out of a different type of material. Accomplishes the same thing to a varying degree. So it has the foot plate. It can be put inside a shoe. In this case, this one is designed, the carbon fiber strut is rigid. The carbon strut, this tall piece right here, that's somewhat rigid. And oftentimes the foot place is a little bit more compliant so that your foot can move a little bit more when you're walking on it. Very lightweight, very user-friendly. Patients give us great feedback on their use. Now, these are often custom fitted. It does not require a mold. It's a different way that it gets billed from a clinician. There's nothing wrong with the fact that it's off the shelf or not. I just want you to understand the differences between why one may have one fee that is charged by to an insurance company or you, and one is the other. Okay, the next one has a posterior or a strut behind the leg again, but then it runs around to the ankle, and it can go on the inside of the ankle or the outside of the ankle. And the advantage is that usually there's a little bit flexibility in your shoe on the instep or the outstep to fit in the shoe a little bit better, which is why they have that design feature. That's the only reason. Whereas the one on the left tends to push the foot forward and sometimes can create a fitting issue inside of shoes. Just a small, subtle difference in the way that is. Oftentimes there's not that much difference between if the strut wraps around on the instep or the inside of the shoe or the outside. Doesn't have too much difference in its function. Now, in this case, that particular design in the center one, that whole upper part, with the exception of the foot section, is very, very stiff. It doesn't bend. And so you get any movement or any compliance during walking in that foot piece again. So patients like it because their foot and ankle can move kind of naturally. They can still get some rollover quite well during the walking cycle when they're walking. But when they lift their foot up and they want their drop foot to be contained, it does a really good job of that. Extremely lightweight. People can barely tell it's even there. And it's a really nice option. That last one, that is a strut type, but there's one on the instep and the outstep. And it looks kind of funny there because you see that it's like slightly bent forward there on the leg, and there's a reason for that. So what they do is they curve that plastic there, which is compliant and it's bendable. And so when you put that on when you put it in your shoe and then you put your leg on it, your leg, just the weight of your leg when you secure it will overcome that bend. And it's like a spring. It's just like a little bit of spring. And that's called a dorsiflexion assist, AFO. It basically lifts your foot up for that drop foot. So it actually provides an assistive motion when you're working. That's the difference. See, so you have the one on the left, you have a strut that's a little bit compliant, no compliance, but you're getting movement at the foot. And in this case, you're just worried about lifting the foot up, and you actually, and it's compliant enough that your foot can go through the whole range of movement. Each one of those become a determinant factor in how you would decide which one was good. And usually your clinician is trying to help counsel you on which one would be best in that case. Okay, I don't know why these two have shifted to the side, but this is another very popular, two popular systems. They are strut AF designs, and the difference is, you may not detect it, this strut is on the front of the leg. So that's a rigid carbon fiber on the front right here. The leg would come behind. The strut's off to one side, either the instep or the outstep. And again, rigid carbon fiber all the way down to the foot piece, same thing here. And then the foot plate is a little bit compliant. So again, what's happening, the main function is to hold the foot during the swing phase so that you don't have the drop foot and you're not going to trip. And then when the shoe is fastened to it, it holds the foot pretty good, and it does provide some stability at the ankle. It does provide a little bit of stability to the knee. It does not replace if you've lost your entire function of your quadriceps or your knee extensors, but it can provide a little bit of stability. Extremely lightweight. It encompasses a little bit more on the leg. And what is desirable from some patients on feedback is that because you have that cuff on the front of the leg and you lean into it, it provides resistance. And particularly for some patients that have worn a device for a while, like many post-polio survivors, oftentimes they like the sense that something's pushing their leg back so that they know their knee's not going to bend. Okay. And so sometimes it's just a little bit more comfort that it's providing that support that they need. Okay. So I hope that gives you just a little bit of insight in the subtleties. There's literally hundreds of more different types of AFOs. But when you just looking at them, unless you actually physically had it in front of you, you wouldn't be able to tell what some of those differences are, because they all look the same in a picture. And I'm only able to espouse what those differences are because I know what these devices are. Okay, we're going to move to the knee now. And I'm wanting to talk to you, give you a little bit of insight as to what a clinician is striving to do to allow a patient to be as functional as possible, and what some of the negative consequences are that sometimes we have to do in that motion control of either the knee or the ankle, that there's a compromise. So we may, depending on the treatment goal. So this is a picture of different segments of the walking cycle. And I'm going to focus in on the ones where the foot is on the ground here in white. Okay. This is where your limb is in the weight bearing phase. The one where you need that stability, because if the knee isn't stable, you're going to fall. You won't be able to bear weight through the limb. So some of you may be familiar, if you're wearing a knee ankle foot orthosis, sometime you have been worn for a while. The knee can be locked, and that's to provide the stability. So when you're weight bearing on it, the knee's always locked. The only time you can bend it is if you physically unlock it so that you can sit down with the KAFO. So that knee movement, if you lock the knee, it creates a huge problem during the walking cycle, because now one of the reasons we bend our knee when we swing that leg forward is it shortens the leg so that the foot does not catch the ground and cause someone to trip. So, and we know this as orthotists, even if we prescribe it, we can't have the knee, we need to lock the knee so that the person doesn't fall and they can stably walk. But now if we do that, and let's say both legs are the same length, you've created that leg is actually longer because it can't be bent during that swing cycle. Okay, what does that mean? There's a lot of new technologies that have come out to see if we can gain in the benefit of giving that back to the patient. And some of you may have a device like this. It's called a stance phase control KFO, or a knee ankle foot orthosis. And what that means is that during the period in walking where your weight is being borne through the leg, it's stable. It's the knee is going to be locked. But when you go to take the step and swing that leg through, the knee unlocks. Now, we've been doing that for years with there's certain types of knee joints that passively can lock and unlock, but there's a whole series of systems out there that give you that little bit. And I'm going to tell you the advantages and disadvantages. Well, why is no one offering that to me? Well, there's some other complications with it. It doesn't make it that easy. So what this is, here's just kind of a diagram of what the components are. So here's a knee ankle foot orthosis, a KFO, a long leg brace, as some call it. And here's the leg section, and it has in this case, it would be a custom ankle foot orthosis. And on the side, there's an upright, and there's a joint here. And what you can't see in the joint is that there's a little push rod. And so when you're weight bearing on it, the push rod goes up and it locks the knee joint. But when the foot is no longer, I don't know if you can see, there's two shells here. This is for demonstration purposes, by the way. And so when the person bears weight through here, this shell collapses onto this one, pushes this rod up, and mechanically locks that knee so that it's always stable when that is on the ground. But as soon as they lift their leg up, the push rod goes down and the knee's unlocked, and you can swing the leg through. And so it makes a big difference in walking, and you have to be trained how to walk like that again, especially with patients that have had post-polio and have walked with a KFO for decades and have adapted a compensating type of walking pattern. With that stiff leg, you got to learn how to walk differently. And it can be, when you've walked like that for many, many decades, it can be such a big change that sometimes this can't even be offered to you because you may not be able to overcome those differences. Okay, the figure on the right is a version of this. It's a little bit different though. That is carbon fiber, and all they've done is they've colored it that nice, pretty blue teal color. And there's a knee joint on it, and that knee joint has a electronic microcontroller in it. So you're not needing that mechanical push rod. This device has sensors in it, so it knows when your foot is on the ground and to make sure that the knee is locked. And it knows when your foot is swinging through to unlock it, to give you a much more natural gait pattern. So, okay, what are the advantages? Well, you get that really smooth gait pattern. You have great stability. You don't have to unlock it and lock it when you sit up and you sit down. It's pretty lightweight. There are some bulky aspects to it because you see that microcontroller and there's batteries and all sorts of things in there. And it's relatively lightweight compared to some conventional systems. So you have that. So you have that benefit. But the disadvantages are that again, it can be a little bit more bulky. And you may have difficulty learning how to walk with it effectively. And it's very, very expensive. And some insurance companies, Medicare, probably don't reimburse for it. So the technology is there. It's expensive. It serves many different people. And all sorts of factors come into play which populations are using these devices. Okay. All right. So now kind of summarize an overview of what I've kind of presented, at least on the post-polio side, is to give you some context to put what I've shared with you. So the first thing is to understand and this is just for the lower extremity, understand what some of the symptoms are from post-polio that start to cause new problems. The progressive muscle weakness, fatigue, joint pain that you've not seen before that's creeped up. And that's complicated by just the normal aging process that has some very similar symptoms associated with it. So you take those two things and you now might be considering more help for you to overcome those challenges that we talked about. You can't be as active, you can't walk as well, maybe stability or tripping. You want to fix those. You want to take care of yourself. And I'm hoping that what you will consider is that maybe some of these decisions are hard, that you may have to move from a device you've been using for decades and decades, and you may have to go with something that's a bit more invasive for you, a bit more orthosis to accommodate you. But what you're trying to solve is you're wanting to make sure that you're safe, you're stable, you can function better, and you have the protection that you need. And so what I'm suggesting is that these are things for you to consider in your treatments decision with your clinicians. So what I'd like to end with is just share with you some of the things that I'm doing in my research lab that can give us more precise answers to help with the decision makings of how we advise patients. So I run the clinical biomechanics laboratory. This happens to be my laboratory that I had at Georgia Tech. My laboratory at Kennesaw State is already built. And so as the name of my lab implies, I'm trying to solve problems that clinicians see in their lab, something that every day a clinician's trying to get. And one of the things that we don't have is that when I talk to you about that motion control and how important it is to control that stiffness of the ankle, let's just say, as an example, how stiff that orthosis needs to be for that patient to perform the best that they can for walking and moving around. Right now, we basically take our best clinical guess at how stiff that needs to be. We don't have a tool that measures the amount of force or stiffness that's required. So here's a picture on the left of a device we created, and it's a proof of concept, which we ended up proving, of a device to create a diagnostic ankle foot orthosis that you could put on a patient in the clinic, have them walk, and it will tell you how stiff the ankle needs to be for optimal walking. So let me show you. So here's an example. This is a device. You can see it kind of has the resemblance of an ankle foot orthosis, a traditional one. This is a carbon cuff with a carbon composite upright on either side. It does have a joint, and it has a stirrup like the old version. And in the back here, it has some springs that are attached to a lever arm, which you can kind of see right here. I have some better pictures of that. And so the idea would be is that you would put this device on, and you'd put it on a patient. You'd have that patient walk with it. And essentially, you see there's springs behind here. And those springs I could control for our experiments. We could control how many springs we put in. We could make it stiffer and less stiff. And we could decide by how much movement is at the ankle that if we could get the maximum amount of ankle movement, still get them to clear their foot during the swing phase, that, wow, we can have the perfect amount. And this is just showing that if we have someone walk, this is the data collected to show the different types of springs. And then we can optimize exactly what the orthosis stiffness should be. So without going into any of those details, I want to show you here. Here's a closer version. So we made it so that it was quite modular. So we could put the stiffening mechanism on the front of the foot and ankle. We could do it on the back. The stiffness sometimes has to be different in both directions. We then can allow that person to walk around. And what you don't see is that, I think I might have a picture of it. We can now have someone walk in the clinic with this device, collect the data, and determine what is the optimal movement that they can get during that walking activity. And here's another version of them walking up slopes, down slopes, up and down stairs. This is something we've never been able to do before. So we have what we've accomplished with this is that embedded in this device, which you can't see here, is we have all sorts of measurement tools. We can measure how much movement's at the ankle. We have force sensors in the shoe and on the device. And we can measure the stiffness at the ankle that's provided by those springs. And so when we walk, we have a computer program that takes all that data and then tells the clinician exactly what the target stiffness should be. Now, this isn't the device that you would wear, but it gives us the number that we want. And then we can engineer the stiffness of any of those AFOs I told you to the desired amount. And so this is work being done in my lab. This is paid for by you as a taxpayer. This was paid for a major Department of Defense grant that allowed us to do this. And so the way that this is going to mature is that you can actually do this on a tablet, a computer tablet. It provides the information wirelessly, and a clinician can monitor it right after you take a few steps and give you that target stiffness that's required. So that kind of ends the formal part of my presentation. And I was hoping to take a little time with some questions that may be a little bit more specific. And those are my grandson's feet when he was born. So I always go back to the feet. So I'm happy to take any questions. I don't know who wants to control that.
I do.
But...
Dr. Kobler,
okay.
You said at the beginning of your presentation that you would talk a little bit about hyperextension.
Yes. Oh boy, I'm not. Let me go back here. I hope it's still in. Okay. I'm just going to use this as a talking point of a slide. So I'll make a couple comments. So as I showed you the image of the treatment goals, hyperextension is this extreme posture. And this occurs, this is often a progressive deformity that after years of walking mostly without any knee control with an orthosis, this can lead to a deformity like this. Not always, but it can. This actually is an extreme version of what knee hyperextension is. It's also called genu recurvatum, genu meaning the knee. And the problems it can cause is, the main one is pain. That at the end point where the knee is always pushed back this far, that usually is what elicits the pain. And so the way we control pain here is by improving the alignment and not allowing the knee to go back to this end-ranged, hyper-extended position. So this would be a treatment goal to reduce pain. How do we do that? We control the motion of the knee by not letting to go into this magnitude of an angle to this. And in most cases, that will decrease pain.
So what
So
are the,
that's a different reason to control the motion. It's just to make sure that we don't repeat the pain.
right, so I've had two replacements on my knee for hyperextension, and I'm going into the orthotist tomorrow to get a brace for hyperextension. So what are the things that he would, or he or she will use in consideration of what kind of orthotic to recommend?
So he's using the same principles that I just explained. So
Yeah.
we're looking at trying to place the knee position in more of a normal alignment, right? Because normally the pain is associated with the extreme joint position that is created.
Right.
And it happens a number of ways. It can be just having this in that extreme position. Can it make it inflamed? And then that will lead to the pain. The inflammation causes the pain. And so you want to reduce the occurrence of the pain. So it can be one-time occurrence where it just goes back. It starts the process of inflammation again. The cycle continues, or it can be the repetitive positioning of it. So if the orthosis that he recommends can limit the amount, the degree, the magnitude that it goes into that hyperextension, that will hopefully decrease the episode where your knee gets irritated from that extreme positioning.
Okay.
So he wants to block the movement of your knee going backwards.
Yes.
So I have the same problem. So to block that movement that's of the hyperextension, would it be a cuff behind the lower thigh?
That's a great question. That's a great question. And I'm going to give you, scenarios so that you have a little bit better understanding. So let me go back a couple pictures here. Okay. So unfortunately, the force system on here doesn't reflect the force system you need to control hyperextension, because the cuff would be back here and here, right? It wouldn't let your knee go back. So what I'd like to, let's just, I don't want that to confuse you. So let's go with it. So one of the things that you need to understand is that the greater the deformity, the greater the magnitude of the angle of that knee hyperextension, the greater the force it's required to correct it and keep the alignment maintained. So let's look at the two extremes. If I put a roll-up knee sleeve over you with no metal joints in it, it may provide a little resistance from your knee from going into that hyperextension attitude, but you can see that's only like the 50 milligram version, right? Okay, so now I have that knee sleeve and I put a couple knee bars in on the side of it. You know, we're going up to 100 milligrams, and you get my point, right?
And I've done both those things, but it's not working.
In general, as a general rule, if I would never use any of those soft systems on a patient with post-polio. You're looking at degenerative joint condition. You might not even see it on an X-ray, but you have joint arthritis that's in that knee no matter what, just from the aging process alone, right? And then the degree, even a few degrees of an angle, can be causing the pain. And the typical off-the-shelf devices just don't have their force system just isn't strong enough to resist that movement back. There's a lot of force that goes through that knee. And so, you look at the knee orthoses that football players are wearing, right? Athletes, those are not designed to prevent hyperextension, right? To the same degree as yours is. And so there's a whole, in most incidences, you usually have to go with more robust materials, either metal, carbon composite, that can control that. And usually you can test it pretty easily. Like if you put the device on and you can still push your knee back with your own hand or by a bit weight bearing on it, then the device is not providing the correct amount of force to help with the problem.
So the devices that just have the circular thing with the hole for the knee, and then they're all soft. That's not.
No,
The
no, they
typical
aren't.
Amazon.
So let me give you a couple scenarios, because you're going to talk to people that said my knee pain went better. My knee pain got better. But what's the reason why, right? So we don't know often why it is, but sometimes if people have mild knee pain, and even with a knee sleeve, and I'm not talking about post-polio, I'm talking about people that just are older, have a knee sleeve with a hole cut out where their kneecap is. It might be that it's just a reminder that they can't bend their knee as much. It might be uncomfortable when you got a knee sleeve around it and it bends and it crumples up in the back, so you never bend your knee all the way. It literally, that is a treatment. That is a treatment, that it's a reminder that you can't bend your knee as well. And for people that have like low grade versions, it can settle the inflammation down and they can get better. So it's not wrong for a doctor to even start to ramp up the treatment, where they might start with kind of, it might be that, hey, if we can just control that movement a little bit, remind the patient to be a little bit more protective with their knee, it could settle down the inflammation and the pain could subside, right? But if it really doesn't, and it's no longer working, you do have to ramp up the design of the KFO. And so I know there's some patients on our Zoom call here that probably have the scenario. You've walked for years and years, no problem with knee pain, and now that's killing you. And you're like, what do I do? It could be that you've held off getting any orthosis for your leg for so long with your polio. And you have, and patients, and this is totally understandable. I can't imagine seeing children walking around with KFOs when you're younger, and that has a horrible sense to you, what it is wearing one of those devices. But at some point, you may have to go to that point to wear a device that's way more comprehensive on your leg than you ever wore to get rid of that knee pain. So the decisions are the patient. Is the knee pain bad enough that you want to try to get rid of it? And then you have to assess when you do. And here's the good part. Let's say that you get a knee orthosis reluctantly, and your pain goes away and you're happy. It doesn't mean you have to wear it all the time. You need to wear it all the time to demonstrate that it's effective at getting rid of that pain by controlling that movement. Once you've done that, then you can find the periods of time where you may inflame the knee again that causes the pain, and only wear it during that circumstance. So it could be that, hey, around your home, you're doing great. You don't have to wear the orthosis. My knee pain isn't bad. But boy, you go walk in the mall with your grandkids and that knee pain starts again. I'm going to wear that knee orthosis because I'm going to be able to walk with my kids. I'm going to come home, I can take it off, and I'm back to where I'm at. So it's learning how to manage the pain using that system for you. And so I would encourage everybody to think a little bit more openly about how you utilize it to treat the things that are bothering you, that are changing your life like that.
Thank you.
I have a question, or Kathy, and this was kind of for Patty to maybe be able to think about when you go to see your orthotist, because I've been dealing with this for at least 10 years and have had 2 or 3 different braces dealing with a hyperextension because my knee just the tendons just kind of gave out. So I have a real unstable knee and it goes backwards. And I've had one brace, a KAFO metal traditional, polio type brace. And had been wearing one he put a strap in the back to literally prevent my knee from going back too much. And that works pretty well. But then I got a new brace, and this one doesn't have a strap in the back, but I control the hyperextension with the band that goes around the upper back part of my leg where the hamstrings are and around the calf. And he's got them positioned so that I have a straighter stance and I actually walk better. However, there seems like there's always a trade-off, because now I don't, with the newest one, I'm still trying to kind of get used to it, and I'll probably have to go back to him for some adjustments, but it is straight, but it's causing the upper bone, the tibia, I think, to go down over the kneecap or the bottom bone, the fibia. And that's causing some pain. If I stand very straight and in that position, it starts hurting, then I have to sit down because I have to rest it, and then I can get up again and it won't hurt. But I'm having problems getting in and out of the car. And if it's hurting, I can't bend over and pick something up off the floor because it causes too much pressure. So, and I didn't have that problem with the strap in the back. But my stance wasn't as straight and I wasn't walking as well, but I didn't have any pain. So it's kind of, those are two different ways to think about it, perhaps, when you talk to them, to try to figure out what would work better for you. But I will say that to take the pressure off the knee, you put a lot of pressure either on your foot or your calf or some other part of your leg, and it will affect you. I have some neuropathy. I know it's from the pressure, but I just deal with it. It's a trade-off. So anyway, those are my little thoughts about it.
Thank you.
Yeah, that's actually a great summary, and it really is the same thing that I see clinically.
Mhm.
And the problems are actually pretty challenging as an orthotist, because we're just trying to mechanically position, hold, and control motion. And then when you do that, especially when you have the integrity of the joint that's often compromised, like everybody's got arthritis.
Yeah.
We start getting arthritis in our 20s and it just gets worse and worse and worse, whether you have polio or not. It just complicates it.
Mhm.
And so, it's constant trade-offs with, one or the other. I'm going to mention another really, really important thing. And this is from clinical experience. At our conferences, you'll find clinicians talking about post-polio cases that they've had and the struggles that they've had with coming up with solutions. And here's an observation that I hope you can take home. So I've had a number of patients through the years where they'll come in and they'll have traditional metal leather systems, worn them for decades. And they'll say, I really want to do something different. Like, I want to know what the newest technology is and all this. And we have it out there. And we're successfully using these devices, different carbon composites, different systems, lighter weight, all these kind of things. For people with similar physical problems, but different diseases. And here's what's happened. We have, with polio, as you all know, it's the motor neurons that got affected. The sensory ones work. They work fine. In fact, to the point that, and I don't know how much this has been documented in the medical literature, but in my clinical experience from observing many patients, is there's almost a hypersensitivity. And when a patient's been fit with an orthosis and has worn that for decades, they know every nuance of how that should fit and interact with their leg, and they're comfortable with it. And they feel it, they feel how good it supports them, and they depend on it. And from that hypersensitivity, it's really hard to even duplicate the same thing for someone, because it's worn in, and you put, you refurbish it, and there's a lot of rejection or resistance to those changes that are made. So giving you that background, I've had several patients that pressed me to make a totally new device out of carbon fiber. Make the device and successful treatments with all these other cases. And the patients, I can't tell you how many rejections we've had. And they end up going back to the old system. It's what's familiar. They feel secure with it. And the reason why I mention it, it's nothing to do with the patient. It's just what makes them feel security when they're walking, and their comfort level with the using that device to help them, that you just can't overcome. And so some orthotists may actually be resistant to offering some of these other solutions because of experiences like I'm describing, where a patient can never, ever adapt to that new device. Especially when you've been walking decades and decades, and your body knows exactly its new walking pattern, and the walking patterns change if you improve alignment, if you let someone's knee bend that's not bent for all these decades. And so I think you need to know if you're that person or not. And the only way it could work is if there's a tremendous amount of open-mindedness, and coupled with the new device, you engage a whole new physical therapy treatment plan, where a physical therapist is now training you how to walk differently with the new device, and you get used to the new ways that interacts with your body. And I think that's really important for you to understand. And there's a lot of practitioners in the field that are post-polio survivors. And they are the greatest ones that give us lectures, because they have personal insight to do this. And so this phenomenon is true. It's not been documented. There's no way for us to measure it, but it's a true clinical presentation that we have with it. So I don't know if that's helpful for your understanding.
It's very true what you're saying.
I have a question.
I've been there, done that, so.
I have a question. My name is Wesley, and I have the traditional long leg brace. But what I'm facing is that the vendor that I've been using for a long time, all of the people there that made the braces for years are retired. Mm-hmm. And I'm just not getting in one or two areas the quality of work that I've been getting. I've been having problems with the knee joints, stuff like that. So I didn't see anything like that in your slides, other than the more expensive brace, which I'm sure Medicare would not, approve. So do you guys?
It's not true that they wouldn't approve them. Like most of those carbon fiber ones I showed you, the AFO versions, those are covered. You're correct that one I showed you, the stance phase control, those probably will not be covered by Medicare. But the knee orthosis that you have is covered. And some of the joints that you can buy to give you different kinds of knee control, mechanical ones, right? Not electronic ones or anything like, some of those are covered.
Okay.
So I don't know how to advise you, Wesley, except for to say that some of the more traditional devices are not used as much. And I'm sympathetic to patients like yourself that are totally happy with the device you have, and you want to keep it. It works for you. You're comfortable with it. And the only thing I could say is that you just might need to do a little bit more networking, perhaps through your group here, in other groups. Maybe it's, maybe someone in the group in the Atlanta area has a similar kind of device, and they have a practitioner that can provide refurbishment to it. And, you know, and I just know that they're out there. Okay.
Yeah, I do too. I
Our
do
basic
too.
training is
Yeah.
fundamental to it. And I
Yeah.
think your best bet is to network with your colleagues.
Hey, group. Hey, group, I'm here.
Wayne,
Well,
this is Shirley. I have a question.
Yes.
Okay, I'd like to know, how do I make an appointment to go and see our presenter? Because I have had this regular KFO since I was 2 years old, and I'm 72 now. So, but I'm having the same problem Wesley's having. Everybody has either died or retired, and it's just seemed not to be the complete understanding of how to really work with somebody who's been wearing the brace as long as I have. And based on your presentation, I would like the opportunity to come in and probably be evaluated by you and your team, if at all possible.
Yeah. So sorry, I might not have clarified enough. So at the moment, at Kennesaw State, we don't actually provide any care there. We don't have a clinic that we're seeing patients through. So and I'm not practicing anymore. I'm not seeing any patients anymore. But I tell you what, Atlanta is probably one of the best areas, one of the better areas in the country to seek care. We have such a rich group of practitioners in the area at a pretty high level. And, you know, I don't like to give out any names or anything, but I'm hoping that, you know, maybe you can set up some kind of a way to communicate on a bulletin board on your website that you know, you can talk to each other to find out who the individual practitioners are that have helped you with maybe take a picture of your device and say, hey, everybody, does anybody have one that looks like this? Are you getting good service at this place or another? I mean, there's no question that the expertise on some of those older systems has subsided a little bit, but the principles have not changed at all. And you know, hopefully there'll be someone that can, you know, care for you. I will say this, and this is totally selfish, by the way. And I talked to Rita about asking, but how I met Rita, and there's another lady in your group, an advocate, Miss Harris. I met some of the members of your group because people like Rita Carlson and Miss Harris volunteered their time to come in and work with our students. We can't treat you, but I tell you what that did is it allowed, because of what happens is patients come in and serve as patient models so that our students can see what someone as polio has, but in an environment that they're not treating them. Because in a treating environment, oftentimes they can't get close enough to the patient to do anything. So they at some point, our program's not going to launch until August of 2021, this next year. But at that point, if anybody would be interested, we don't pay anybody, but we do reimburse people a little bit for their time, and we're now providing reimbursement for travel. And we have these sessions that you interact with our students with, and I can explain all that later. But selfishly, I would hope that some from your group would continue to support the program when we're up and running.
Can I make a statement?
Please.
Thank you. First of all, your presentation was awesome. Thank you so much. I did notice in the beginning of your presentation that you were, I don't know if you worked or associated with Arthur Finiston down in Miami.
That is correct. That was early in my career.
Well, when I left New York 50 years ago, I was told only to see Arthur Finiston way back in the day. And I think they were located on Coral Way, if my memory is correct, or near Coral Way.
You are good. When I worked there, they were on Bird Road.
Okay.
In Coral Gables.
Yes, yes.
And I actually I met Arthur Finiston. I worked for his son. He was retired at the time.
Okay.
And I met Arthur, and I can't say enough about that gentleman.
Well, this
He did great work in Miami. His actual son now is retired.
oh wow.
But I knew him really well. He was a great man. It's so great to know that he cared for you.
I met him in the 70s, and then I was in plastic. I was in aluminum and leather, and then in '84, after I had my son, that's when either he or somebody there suggested plastic, and I think you may have remember him. I think that's where I met Peter Bukacheski. If I don't know.
Yeah, I was there before. I was there before him.
Okay.
I was there in 80. Yeah,
Okay.
I was there in like 83, 84 through
Okay.
86.
Well,
I
I'll
was
never
there
go
when you were
back.
there.
I love my plastic. I love the plastic, but like you say, we know the brace has to be tweaked exactly. And if it's not, I mean, it takes me 3 months with the new brace, 3 months for them to get it right. So I'm their worst nightmare. But anyway, thank you.
Hey, my name is Ravi Patel. I'm actually fairly new to the group, I'm 41, so a little younger than most of the folks. But I've had polio since I was about 6 months old, and pretty much everything that you mentioned about leg discrepancy, foot size difference, deformity, I have all that on my right leg. But I guess given my personality, or maybe because I'm younger, I'm always willing to try new things and just go out and experiment. And in fact, I used to have a shoe lift on my shoe, but at one point I realized, well, why can't I put the lift on my brace and then slide my shoe? So basically we changed the angle of my foot, and then I started putting the lift under my foot plate of my CAFO instead of on my shoe. So you don't see the lift anymore, but it's taking care of the discrepancy. And then in past July, I actually had an osteotomy done to correct my, what is it called, a knock knee. So one of my legs, my polio leg, my foot kind of sticks out. So I had an osteotomy done with Dr. Terrell. So that, I was kind of scared, but it all worked out. But I had a few different questions, but I'm gonna, because given the time, I'm limited to just one. Speaking of CAFOs and technology, you mentioned about a lot of folks coming in with master's degrees and technology technology advancing, but that specific CAFO that you mentioned about, it's got some electronic features where it automatically kind of unlocks the knee portion. Given the fact that I have like zero motor in my right leg, the only thing I can do is like move my toes a little bit for a bar trick, but that's really it. And so for a person with like my limited motor abilities, compared to probably a lot of folks on this call, would that type of brace work for someone like me? Or do you think that would go more towards someone who has some motor function, maybe not, 100% like a quote unquote normal person, but enough? But that's kind of really my question. And thank you. And great presentation.
No worries. So just so that you understand, so I categorize those as stance phase control, KFOs, meaning that during the weight bearing part of walking, they're devices that specifically allow your knee to flex, right, through that swing phase. So, and the goal is to provide stability during that stance component, but flexibility during the swing.
Okay, so
there are a lot of different, yeah, and they're not all, like some of those are just mechanical. So I showed you a mechanical one where there's just a mechanical joint that locks and unlocks strategically. There's some that just use electronic sensors on the lock that lock it and unlock, right? It uses a pressure sensor that says it's a foot on the ground or not. And then there's microprocessor knees that are there that can control function of the ankle and the knee. Those exist. The technology is there.
Mm-hmm.
Those are tens of thousands of dollars on that higher end version. And there's no question that you could use a device like that.
I've seen that.
Oh, really?
However,
getting one or
think of it this way. Think of it this way. In prosthetics, as everybody's seen, people are walking around with a prosthesis with no function at all, And the computer on that knee can sense where it is, and people can walk up and down and never fall. The technology, there's a little difference. When you have limb loss, there's places to stick motors, batteries, and all that, right?
Right.
When you have an existing limb, which we're talking about with an orthosis, there's not as much space to stick that stuff, right? So, so the technology, to apply that technology that we know in prosthetics and apply it to orthoses has been there for a while. It's just taken a little bit longer. And because the mechanical passive systems we've been using for literally centuries have been so effective, and the cost comparison is so different, is one of the reasons why you don't see wide use of it. So the answer to your question is, I am pretty sure that a microprocessor knee, ankle, foot orthosers can be designed to control your walking with that device, right? And allow you some of those benefits we talked about, where your ankle could still move, your knee could move, but at some point you have to benefit the weight of the cost for that, how much more functional it is compared to like a passive system. And that's where the clinical decision comes in.
Right.
You know, the technology is there, but it's often not useful. I can't tell you how many upper extremity powered devices there are for the hand that are never being used because someone has another hand. And even though this one can do all sorts of fancy things, it's not going to happen.
Right. Yeah. Yeah. No, thank you very much. That makes total sense. And, you know, one last kind of comment, I guess, like, you know, a lot of times in orthotics, you know, it seems always like prosthetics is always more advanced than orthotics, but even in orthotics, it's more about functionality than aesthetics. And I think there are a percentage of us that also care about aesthetics and the way we walk, and we want to be quote unquote more and more normal. And so these kind of things may not add more functionality, but if it helps us kind of feel more normal in a way, it's awesome. But thank you.
You know, I'm going to follow up on a comment to that. I'm old enough and have been in the field long enough that there's been some huge advances in this area. When I first started in the field, if a patient was fit with a prosthesis or an orthosis, they'd want to hide it.
Oh yeah.
They put pants going down or whatever. Let me tell you what, in today's day and age, at least here in the US, different cultures have different things going on. But right now, the technology and innovation is so much in society and ubiquitous. People want to show everything off now. They want to show their carbon leg off, their carbon fiber leg. They want to see the motors. People are intrigued about it. They literally don't want it covered. We're not making covers for any of those anymore now.
Right.
And I've seen the same thing with orthoses. Okay. So those carbon fiber orthoses are quite low profile, right? You barely see anything. And it depends, especially with the younger people, they want to show that off.
Right.
So with some generational shifts, and I'm not including you in this group, by the way, but some of the generation shifts, you know, they still feel a little bit more comfortable not to show kind of the devices they're being treated with. But we fit kids, we have all sorts of fancy they're not stickers, but they're transfers that go to the plastic. Kids come in and the decision to fit them is what transfer they're going to pick to go on their AFO. They don't care about anything else. They want to know if it looks like tattoos or it's got little flags on them, whatever. So those things are really kind of being self-resolved. It's great to see society way more accepting of the things that we're wearing right now. And so there is making a shift now.
Sure. Yeah. Thank you very much. Yeah.
This is Shirley again. I have another question. I saw on the TV not long ago at a golf course here in Atlanta where someone had been in an accident, but they were in a device that lifted them up where they could actually play golf. Are you familiar with what that is?
I am.
Okay.
That is, and the reason why I know, I've been attending some of those golf sessions
Oh,
I'm not a golfer, but I was invited to participate, and we have people that are totally paraplegics,
mhm.
and but they have upper body function. And actually, one of these gentlemen actually has come in and spoke to my students.
Oh,
And this particular person I've seen here in several tournaments. They actually that golf. I can't remember the name of the association that sponsors it, but they actually bring the technology to the events that they have, and they don't own it. It's there for them. So it's basically a wheelchair that basically allows them to stand up, and they can use it. There's a company called Ottobock, OTTOBOCH, sorry. And they're the company that makes that system. I can't remember what it's called right now.
Isn't
By
that
the
the
way-
exoskeleton?
Shirley, by the way, in the chat, several people have suggestions for brace makers in your area.
thank you.
I have a question. This is Rita. How much does Medicare pay on any of this? Do you know, for the braces and stuff?
You know what? Because I'm not in practice down here anymore, I really couldn't even give you a close comment right now. Usually, it's not too bad. I'd say it covers about 50% to 3/4 of the amount that practitioners typically charge.
I think they have
It
negotiated
depends on
the rate.
It's dependent on the device. The devices
They
are.
they
totally-
negotiate the rates too, with the, like with CH Martin, they negotiated the rate that they would pay for the brace, and CH Martin just accepted it. So it kind of depends on who's providing the brace as well.
Yeah, I went to Hanger and my brace was about $1,700 if I remember correctly. And I had to pay about
Mhm.
$700 of that.
Yeah, there is the range is really, it's so huge. That's what's even hard to make a comment,
Mhm.
because there's certain versions there that it's almost completely covered, particularly if you have a supplemental insurance, and it really just depends on the device itself and how it's built out. Okay, does anybody have any other questions? It's been a pleasure speaking with you. And
Thank you.
at some point, we will have an open house at Kennesaw State. When the pandemic clears up, that could be years from now. But at some point, there'll be an open house, and I'll find a way to post it, and would love to have some of you come and see what we're doing there.
Thank you.
Doctor, I do have a question. Did I hear you say you're building a new lab?
Yes, we are.
We need to talk.
We're building brand new labs because the program's just moved over there.
Okay, well, we sell laboratory furniture. We need to talk.
Thank you, Dr. Kobler.
Yes.
Thank
Okay,
you so
one
much.
more
So
question.
much.
For your wonderful presentation.
Yes.
Awesome.
Can you hear me?
Yes, I can.
Okay, the question is, so I'm wearing the carbon fiber device, the one you had the three of them up. The black things you said, they're flexible, you stick it in your shoe.
Yep.
So I was wearing it for about a year in 2019. And it appears, and I want you to tell me, is this just my imagination or is it real? It appears, it feels like the upper part of my leg, my thigh area, was getting weaker the more I use it. I started working, and so I would use it then when I came home, and if I go to the store, I probably wouldn't use it. But I don't.
Yeah, I don't think that you're imagining that at all. So that brings us to kind of what we know about post-polio syndrome, doesn't it? That you can have some progressive weakness, and perhaps compared to the other device, which I don't know what it was, but it might be the way that you're using that new AFO. Perhaps forced you to use your upper thigh muscle more than you did previously. Who knows what degree it did? And that change could have put you over the top with feeling that way. So that doesn't surprise me at all.
Okay.
I think that that's normal. And unfortunately, there's no way for us to predict how someone's going to respond to the use of the device to know that would have occurred or not.
Okay. So is there anything with the therapy, can I do anything to help strengthen that thigh part again, or is it at this point, it's just going to just continue to get weaker?
Well, I wouldn't worry about it getting any large magnitude weaker, right? We don't know we don't know the prognosis of where an endpoint is.
Yeah.
And you know, we don't fully understand the conditions of this weakness well enough to know like what the implications of exercise is on a muscle after in post-polio syndrome, but we're concerned about it to the point that so the answer to your question is, I would try to get with a physical therapist who has experience with working with post-polio syndrome and be evaluated, because they can monitor the strength of that muscle, and it may be that it'd be like, we're not going to do any strengthening. That would not be helpful, but at least you'll know what you can do. And maybe the design, that maybe that AFO has to be switched out so that you're using less of that muscle. But you really need a physical therapist to kind of help with that assessment.
All right, I appreciate that.
All right. Well, thanks everybody for your time and your patience. It's great speaking to you all.
Thank you.
Thank you so
Thank you,
much.
Dr. Kobler. This
Bye
is
now.
Iris. Bye-bye.
Bye.
Thank you.
Oh.